I would like to take the $4 billion that the government is saving but with family caregivers and use it to really improve some of the conditions that we see in other settings, but seeing as it might not be that straight a transfer of dollars, what strikes me is that we have I think it would be fair to say, at least in some quarters, a beleaguered family care workforce that's paying a pretty steep price. And we have a formal care force, a paid workforce, that also is under some non-trivial levels of distress. And that's a direct area of policy implication and resource consumption that we ought to or could apply some significant effort to together, not in isolation, because I think that we looked at both groups when we have at least looked at them in relative isolation of each other.
The other comment that I would make is I am definitely in favor of a move of resources, but I don't know that necessarily an increase in staffing, for example, in a long-term care facility is what will totally make the difference. And that's because I think we have cultures of care that they're not orientated yet to the population of people that's in front of them. So we need more care providers, but we need more care providers that are oriented to the care that they are needing to provide.
Thank you. Yeah. Tamara.
And I think I would agree with that, but I think we kind of need to have more care providers at the same time as work to ensure that we get the skills in place to address the needs of dementia. I also think an important point is that other models exist, and we can look at those other models and import those other models in a way that meets the context that we have here in Canada. But I would still argue that the level of staffing is actually a critical issue, and it's a critical issue for a couple of reasons. It's a critical issue because the people who are in long-term residential care aren't getting the care they need. They aren't getting the timely care they need, and they're not getting sufficient social engagement. And for the second reason is that if we don't fix the working conditions, we won't be able to get good people to do the work. We have dangerous working conditions in long-term residential care. And we need to be very cognizant of the health of healthcare workers. I think that's a really, really critical issue. And we still need to remember that it's still mostly women who are doing a double care shift if they're the formal care workers. And I think it's still mostly women who are doing the so-called informal or unpaid care as well. And those are issues that I don't think should drop from our discussion of what it means to have dementia and also to care for people with dementia.
One more quick thought, Tamara.
Yeah, I just wanted to respond to the last point. The gender gap in so-called informal care, the family friend care, is actually closed quite a lot. The proportion of Canadian family caregivers who are men and women is almost equal now. It's like 49-51, something like that. But there are other gender differences besides participation rates. Women caregivers tend to spend more time. They tend to do more of the personal care. They tend to do more of the emotional care work. So there still are big differences in terms of the type of care that's provided by men and women, and that translates into a much higher likelihood that women will experience those negative consequences that I talked about.
That's interesting. First question, who has the mic? Okay. It's hidden in the crowd, and then maybe you could give it to the person next to you because she had her hand up last time and didn't get met. Yeah.
Okay,
so,
absolutely.
Yeah.
Janice Keefe, Mount St. Vincent University. Thank you for a very interesting and important discussion of bringing forth the workforce, both paid and unpaid. One area I'd like you to comment on, just because of the nature of our demographic situation in Canada, where our bulging baby boomers had fewer children, and for most of them, it's a bit too late to start now. And so we have much less rates, or higher rates of women and men who do not have surviving children into the future. And so these expectations that there will be unpaid family caregivers available to them is getting even more problematic. And I guess I would add to that just the challenges we have with our demographics and our workforce, because where are we going to get the numbers of individuals in the workforce to take up the slack that the family caregivers who will no longer be there with shrinking networks. Obviously, we may have more spouses, but we will likely have less availability of children to provide care. So I would like you to comment on that too.
Well, and I think we have to talk about what we mean when we say the word care. Because in Sweden, when you say you're caring for your mom or dad and they're in long-term residential care, or you're caring for your spouse, you're going there to visit. You're not going there with the worry that you actually have to provide basic personal care. And you're not worried about having to sit there and make it in time for the dining hours so that you can sit there and provide proper feeding so that your mom or dad or your spouse gets fed, with enough time so that they can consume enough food. So I think that this notion, we need to value long-term care, but we also need to think through some of the issues around how much time it takes to care and what sort of care we want family, friends, and volunteers to be engaged in. I think it's really wonderful to think about creating long-term care facilities that are not warehouses, where they're actually active places where lots of people come and visit. But we shouldn't fall into the trap where we think that family or volunteers or students or even people that you hire privately to come in because there aren't enough workers there, we shouldn't fall into the trap of thinking that that can solve the system's problems. The system needs to be fixed with appropriate staffing levels so that people are cared for appropriately, and all of the rest of it is what makes residential care a more joyful and engaging place in which to live and then eventually die. That's what I would argue.
Beautifully put. Thanks. Jenna?
I have a somewhat different perspective on the future of the supply of family care than Janice has. We've had this conversation before. I think Janice is right that, because of smaller families and more mobility, geographic mobility, because of the fact that more women are in the workforce and all of those kinds of things, more childless families, I think all of those things are shrinking the pool of potential family caregivers or family friend caregivers. But the fact is that even when we have had larger families, there's been one or maybe two family caregivers in the network on average. I mean, that's hiding a lot of variability. But so I think the main effect that all of those changes are going to have is that it's going to bump up the likelihood that any one family member is going to be the caregiver. So if you're the daughter or the daughter of, in a family with two children, then you can pretty much count on the fact that you're going to be a family caregiver. I also think that there's going to be an increase in the role of more distant family and in particular friends and neighbors. It is currently the case that 20% of that family workforce is actually friends, and that's why I use the term family friend caregiver for the most part. And so I think that there will be an increasing role for friends and neighbors. And what kind of care they'll be prepared to provide, how many hours of care and those sorts of things, I think remains to be seen. But I think that there will be additional pressure on that family friend, the pool of potential family friend caregivers, because it will be smaller.
Okay, we're going to try to get in two more questions, so I'll go to the woman with the mic and the black and white top. Yeah.
Pat Armstrong, York University.
Hi, Pat. Yes.
I wanted to pick up on something that Anne Martin Matthews raised earlier today on cultural differences that I would like to raise in terms of all of the four presentations. And of course, as Tamara knows, in terms of what this means with the number of immigrant workers and temporary foreign workers we have in long-term residential care.
Is it a question or just a...
It's a question.
Okay. Two of you can speak to it. Or none of you.
I'll say a little bit about family caregivers. We know that that immigrants in particular are less likely to seek formal medical care of all sorts, and that applies to long-term and continuing care as well. So the likelihood is that there will be higher expectations that family members will be the primary caregiver, and it reduces the likelihood that they will get much support in the form of formal care, whether that be home care or long-term care. That's about all I can say.
The workforce in long-term care is becoming increasingly racialized. That is to say that there are more and more immigrants that are in the workforce, and of course that's place dependent. So if you go to parts of the country where not many immigrants live, you won't find many immigrants in the jobs, but especially in larger centers, you will find large numbers of immigrants. And one of the challenges that we hear in our interviews, especially in Toronto, is that they don't find that they are making a sufficient living off of just one job. So we've heard that they go from the one job and then they go to a second job where they're maybe doing private care for someone. And then recently we've heard of people who are now doing a third job. So they effectively are working 24 hours a day because they're going to sleep at somebody's house, because that person just needs someone to be there in the evenings. So we've created kind of an immigrant ghetto in this labor force, and we're putting increasing pressure and stress on this labor force, and especially because we're drawing on the advanced degrees that a lot of immigrants come to Canada with, so they have much more training, and as a result, they're not very happy as well, because the jobs are very flat in terms of a job hierarchy. So if you are a personal support worker, you don't get to then become something else. If you start day one as a personal support worker, 25 years later, you're still a personal support worker. You've not had an opportunity to advance your own skills or your own job progression. So I think we need to think about some of these things if we want to continue to engage people in the work, if we want to make sure that it's excellent working conditions, and if we want to make sure that we have equity in terms of who's doing the work.
Thank you. Time for one more question. This is a cluster question set. So, yeah.
Dr. Banerjee started us off this morning by talking about the tyranny of numbers, and I'm really struck by how many of the things we're deconstructing here we can do because we have numbers associated with them, and I think it can lead to simplistic solutions sometimes. All of you have mentioned the value of relationships, and that's really not immeasurable. I read a recent Ontario paper that I thought was really telling about the inadvertent, unintended consequences of the sort of high priority about the 5-star dining model of long-term care. Families want it. That's the selling point. It gets itself built into evaluation accreditation standards. And from the care worker point of view, it dominates the daily workforce. It becomes the organizing structure of morning, noon, and night, and getting people nicely dressed, cleaned up into a facility in which the meal looks like normal 5-star dining. And what we don't have is mobilization, and we don't have relationship building. I think that kind of study just strikes me as some of the things we should be doing and looking at, because you need pieces like that to add to the information that you've got to say what is within our control. Some of those administrative structural issues that we build in as an illusion of quality are probably complicating the situation as well. I'd love your comments.
I absolutely agree that we need to think about things at a sort of an organizational level that can enhance quality of care. But I also want to be careful about one point. I actually think that these are system level issues. I think that oftentimes workers would more than gladly engage in exactly the type of care that you're talking about. In fact, that's often why they've entered the profession. But what ends up happening is that they're driven by the clock. They have 12 people to get up in an hour because breakfast is served from 8 to 9 a.m. And then they have 12 people to make sure that they get fed. And so they're driven by this clock and this need to get people ready for the day. And the additional problem is that we have a huge amount of oversight in long-term care because it's a vulnerable population. But with that comes a tremendous amount of paperwork. And that paperwork often drives the work organization on the ground level. And that as well is a system issue. So if we don't think through very carefully how our health policies transfer down to the organizational level and what it means for frontline care work, I think we're going to actually end up with a lot of problems in this country in the future.
I agree, Sally. I also think that we have to keep counting because it's very difficult to know where we get to if we don't know where we've been. I think in all the comments I've heard, one of the things that hasn't been said, but it's implicit, and I think we all understand it, is that dementia care is complex. It's incredibly complex. But I think we've minimized it and we've relegated it to how hard can it be? These are old people. They're going to die. We just have to keep them clean, and maybe free of pain, but actually that's not the case. A good dementia care to engage people socially and keep them mobile and give them some sort of pleasure and help them with moment-to-moment existence, which is, because they don't have a temporal idea of life like we do anymore. It's complex. And we've put the least equipped people in the system with no training in place with 2.9 hours per day of paid work hours on average, paid work hour, or unpaid, like the real work hours. And we think that that's enough. Now, maybe it is, but many of us would submit that we need to really examine carefully whether in 3 hours a day you can provide what's needed if we choose to value high quality of life at this stage. And I continue to think that the value issue is our core problem in this sector.
Okay, so I think that's going to wrap up the questions. I think Carol would like to do a sum up. She's changing roles again. So as moderator, I'd like to thank the panelists. So thank you very much. And we just have a few more questions and then we'll have a quick break. Not questions, comments. Sorry.
So thank you very much, everyone. We've been down in some considerable level of detail trying to highlight, certainly not all, but a smattering of the core challenges managing well with people at this stage of life. But if we go back to some of the comments earlier this morning and to a comment Diane made just a few minutes ago and think about what is the challenge in front of us in terms of thinking of how we would ask questions that would lead us to solutions that are truly innovative. How would we raise questions that would lead us to new knowledge or put together knowledge that would help inform policy in a genuine way? How can we shift from a perspective on caring for people in the stage of life that can have a dismal outlook to one that's much more optimistic? And how do we think about systems of care with the same excitement that we muster when we think about a cure, or we think about a really meaningful intervention or treatment that's going to modify this condition? So I'd like us, as we go for coffee, to try and get back up to higher level and think about what we're going to be coming back to at the end of the day, which is what kind of questions could this academy address that would lead us to understand better or inform better policies around systems of care, given that it is unlikely that we're going to be able to wake up in a year or two and give everybody a vaccine or a pill that's going to make it all better. So.